know that there are some prescription medications out there that are helping women tremendously, and one I can think of is called Vizan, that was just approved, I know, in Canada recently. I'm not sure how long it's been available in the States, but is that helping women?
So there's lots of options, and I think that when we talk to women who have pain, we want to make sure, or they have endometriosis, is to communicate that there are many options with them. I'm very supportive of alternative medical options as well, as long as it's two things: doesn't cost them too much and doesn't hurt them. And we support things like cognitive behavioral therapy or mindful meditation, changing their diet, and improving their quality of life and decreasing their stress. But if there are a lot of medical treatments available that have been studied and have good evidence. And I think that internationally there's good agreement that good medical therapies can be started. So Dynagest, which is the generic name of the medication you just discussed as well, is a available progestin. So the woman's body makes estrogen and progesterone. This is a progestin which deals with endometriosis-related pain. Many studies have supported it. It's a once-a-day pill. So if the birth control pill doesn't work, we've got other pills to take. And then down the road, there's some other medical options as well. Many options. I would really encourage women to talk to their practitioner to get a balanced viewpoint. And there's a lot of stuff available on the internet, but there's some reliable sources as well on the internet. One of which I'll plug right now is endometriosisinfo.ca. That's a website I helped make with the Society of OB-GYN of Canada. It's got very reliable, very good information for patients.
So at what point do you and the patient decide, okay, we've tried the anti-inflammatories, we've tried some of these mindful techniques, we've tried some of the prescription painkillers. At what point do you sort of begin to look at surgery?
So surgery is always part of the option regimen. So if they're not doing well with whatever treatment they were provided with, we need to provide them with the whole menu, as I would say. So if we're going to talk mainly about pain, because infertility is a bit different, I think pain is what we should maybe focus on for now, I give them the menu. And I say there's some good medical options we haven't tried yet, so why don't we look at those? And if they're not doing well or if they failed medical treatment, then surgery certainly has been shown to be effective to reduce their pain. And laparoscopic surgery or minimally invasive surgery is the way to go. There really is no role for a big cut or a laparotomy in these cases. And so laparoscopic procedure where you make a diagnosis and treat at the same time is the way to go for some patients. So I think that it depends on the patient's current status. The other reason to do surgery in these cases is if you've got a big mass. So the ovary has a huge cyst that we're not sure if it's endometriosis or it might be something else. We want to get a diagnosis. That'd be another reason. So there are very rare cases, although when your listeners are probably listening to this, they probably have some of these symptoms. We look at other symptoms to perhaps suggest surgery is more appropriate. So some of the symptoms with endometriosis were painful periods, pain during intercourse, especially deep pain, painful bowel movements. So the more of those symptoms they have in one patient, the more likely they may need an intervention like surgery as well.
So when you go in with the scope, can you actually see whether or not there is any endometrial tissue in the bladder and the bowel?
Yes, and so there's different types of laparoscopic surgery. And I think most gynecologists are very good at dealing with early stages of endometriosis. When the disease gets more severe, involves the bladder or the bowel, then you really want to see an expert who deals with endometriosis mainly. And that is a completely different disease because the risks are higher and you want somebody who can manage all of that.
I know that you are one of the leading, if not the leading, surgeon in Canada for that, removing that type of disease or that type of tissue. Would you agree with that? That you're probably the person to go to in Canada.
I'm one of the few. There's a very good colleagues across the country, and so in each area, I'd encourage a patient to find out who their local experts are.
Right.
And we all know each other, and so in Canada, there's a small network,
Okay.
and we can refer. In the U.S., similar thing, where you basically become an advocate for yourself as a patient, and you do your homework and your research, and it's word of mouth, but also through organizations like the World Endometriosis Society. You find out who's involved and who has an interest and experience in this area.
I say it's like shopping, right? And I say in the book, I think sometimes women spend more time shopping for their shoes than they do for a doctor who can treat their symptoms, right?
Yep.
So what I'm hearing from you is that, you know, you have to ask. And I know the term that you've used before is deep infiltrative tissue. So is that the type of language women should be using? Like, hello, I'm looking for a gynecologist who has expertise in removing deep infiltrative tissue.
I think we've done a good job now with your help and others' help of getting the message out. So most gynecologists now know what their limits are in terms of what level of endometriosis they would do, and they would first go with the consultation, and patients often need a good evaluation. And the questions that patients would want to know: is my bowel involved? Is my bladder involved? How severe is it? Is it something I can manage medically, or do I need surgery? If I need surgery, can you do my surgery, or do I need to be referred? And most physicians are very open to discussing this. Well, that's what I hope, at least. And I think that that's a good dialogue that patients should have. And we're going to get more advocacy on this topic as the time goes by. Most people who don't have experience with a deep disease, which is, let's clarify for your listeners, deep disease means invading the bowel, bladder, and other organs.
Right.
Most gynecologists are very good to say they don't want to do that type of surgery if they're not experienced because the risks are too high. Then they would refer those patients off.
Risks being perforation?
Yeah. So the risks of laparoscopic surgery are injury to the bowel, the bladder, blood vessels, and the risks go up significantly as you move forward with the more invasive procedures.